All right, everybody, we're going to go ahead and begin here. I'm sure some folks will be filtering in shortly. Hello, my name is Scott Perkins, and I am today's presenter for this CE program. This continuing education program is part of the InpharmD CE Masterclass series, and this is the second CE as a part of that series. So if this is your first time, welcome. Glad to have you here. And if you were at our last CE in August, welcome back. If you've never been a part of one of our CEs before, we do things a little bit differently. I'm very much opposed to just showing you a bunch of slides and talking over them. So I'll be popping in a little bit with some different video-based content and some animations and trying to take a more innovative step and approach to what we're doing with some of our CEs. Excellent. So let's jump into it a little bit. As I mentioned, this is a CE that's part of the InpharmD Masterclass, and sort of the idea behind what this masterclass is supposed to be is, well, InpharmD has a drug information database of about 10,000 different requests that they receive from healthcare providers across the country. And what they've found is that if you have a request and you request something from InpharmD, there's about a 40% chance that some other provider out there has already asked that same question, or at least a very similar question to that. And so what they're doing with this masterclass kind of series is trying to answer the question that you might have before you even ask it. So kind of eliminating some of that redundancy in order to give you information that you can best use for your individual patients at the time you actually need it. So it's InpharmD's goal to kind of review some of the most commonly asked questions that they have in their drug information database on a month-to-month basis and present a continuing education program on the literature associated with that question. So if you find this interesting and you're interested in reaching out to InpharmD with a topic where you have a general clinical question that you'd like for InpharmD to investigate for a potential CE, feel free to reach out. Janvi at InpharmD.com. It's Janhavi. You can reach out to her and she can help get that on the fast track to developing a CE for you. Excellent. This is myself and Janvi. Janvi is the director in brand development here at InpharmD. She's helped put together the content for this CE today with help from some of the InpharmD researchers, the drug information specialists that work for InpharmD, and those individuals who answered some of the questions that were asked on this topic we'll be discussing today. And there's me on the left side there. I'm Scott Perkins. I'm a co-director of drug information here at Campbell University's College of Pharmacy and Health Sciences, where I'm also a clinical associate professor here as well. So I'm happy to jump into today's CE, and I hope that you find it engaging, and I hope that you learn a lot about the topic you're interested in. Before I begin with that, neither Dr. Punyarthi or myself have any relevant financial relationships with any ineligible companies to disclose for you all today. So our topic is, what does the evidence say about rebound COVID-19 after Paxlovid? Just as a disclaimer, I'll be using both Paxlovid and nirmatrelvir, ritonavir kind of interchangeably throughout the presentation today. I try to keep the brand name out of most of the presentation, but I'll use it at the top of slides or things like that. But the body of those slides might have just be focused on the generic name itself. So that question comes from a series of questions that InpharmD has received from different providers, again, at different organizations. And so, again, the idea is to eliminate redundancy and to answer the question that you might have before you ask it. And so we were asked a question in June where someone asked, what is the data for the efficacy of nirmatrelvir, ritonavir, or Paxlovid for newer COVID-19 strains like Omicron? But then also, what is the data regarding COVID-19 rebound symptoms after taking a course of nirmatrelvir or ritonavir? And what are risk factors that may predispose patients to those actual rebound effects? Again, In August, we were asked a very similar question. Why do some patients experience rebound COVID-19 after Paxlovid or nirmatrelvir or ritonavir? And what is the incidence of rebound COVID-19 after a course of nirmatrelvir or ritonavir? And so with that in mind, we've developed this CE. Again, we're going to be popping in and out with some different video-based content for learning, a couple of different activities in between, some knowledge checks. So for now, I'm going to get ready to jump into the actual presentation itself. Our objectives are, upon successful completion, pharmacists should be able to recognize the basic definition and signs and symptoms of rebound COVID-19 after nirmatrelvir or ritonavir, discuss the incidence, clinical course, and outcomes of patients treated with nirmatrelvir or ritonavir, describe the current hypotheses concerning why rebound COVID-19 may occur after nirmatrelvir or ritonavir, and assess the current literature regarding rebound COVID-19, and then finally, to identify some of the strengths and the weaknesses of the evidence that we'll discuss later on today. So with that being said, I'm going to send it off to our first segment, me in our studio. So we'll see you on the other side.
Paxlovid and ritonavir, a combination antiviral and protease inhibitor that goes by the trade name Paxlovid, was approved under an emergency use authorization in December 2021. Under this EUA, this combination is approved for the treatment of mild to moderate COVID-19 in adults and pediatric patients 12 years and older who weigh at least 40 kilograms with positive results of direct SARS-CoV-2 viral testing and who are at high risk for progression to severe COVID-19, including hospitalization or death. Patients should receive Paxlovid or ritonavir within 5 days of symptom onset and be reserved for patients with mild to moderate illness, have one or more risk factors for progression to severe disease, and who do not have severe renal or hepatic impairment. Under the EUA, this agent is not authorized for initiation of treatment in patients requiring hospitalization due to severe or critical COVID-19, for pre-exposure or post-exposure prophylaxis or prevention of COVID-19, or for use longer than 5 consecutive days. Nirmatrelvir and ritonavir should be administered orally without regard to food at a dose of 300 milligrams of nirmatrelvir and 100 milligrams of ritonavir. This is 3 tablets in total, 2 nirmatrelvir, 150 milligram tablets, and 1 ritonavir tablet. This is taken twice daily for 5 days. For patients with moderate renal impairment with an eGFR between 30 and 50 milliliters per minute, patients should only take 1 nirmatrelvir 150 milligram tablet and 1 ritonavir tablet twice daily for 5 days. This combination of nirmatrelvir and ritonavir should not be administered to patients with an eGFR less than 30 milliliters per minute or those with severe hepatic impairment. The child Pew class C. Anyone with a history of clinically significant hypersensitivity reactions to any component of this product should not take nirmatrelvir and ritonavir. Along with this, it's also contraindicated with drugs that are potent CYP3A inducers, where it's thought that lower plasma concentrations of nirmatrelvir and ritonavir may be associated with the potential for loss of neurologic response and possible resistance. This agent cannot be started immediately after discontinuation of any of the following medications due to a delayed offset of the recently discontinued CYP3A inducer, including drugs like carbamazepine, phenobarbital, phenytoin, and rifampin. In addition, nirmatrelvir and ritonavir are contraindicated with drugs that are, or rather rely heavily on CYP3A for metabolism and clearance. Such agents include cardiovascular agents like amlodipine and flecainide, antipsychotic agents like clozapine and urazidone, and statin medications including lovastatin and simvastatin. Adverse effects of this medication include dysgeusia or taste disturbances, diarrhea, hypertension, and myalgia.
Okay, it sounds like for some of you all that segment was a little bit muffled. So we'll try to get that next segment to sound a little bit better. So my apologies about that. All right. So before we move on, I have a couple of knowledge checks that we'll jump in. And we'll work through these. I'll answer some questions and then we'll jump on to another segment. So first, what I'd like for you all to do is to read the prompt that you have before you and answer in the chat, if you will, what you believe to be the correct answer. So in this case, our question is, Paxlovid can be administered to what types of patients? See some answers coming in. A lot of votes for C. Fantastic, right? Okay, so yeah, overwhelmingly, I'm seeing C. So let's go through the answer choices and rule them in and out. So answer choice A, patients undergoing dialysis. For these individuals, it is actually not recommended to take COVID. Anyone with a eGFR of less than 30, we don't really have a strong recommendation to deliver or provide Paxlovid to these individuals. Patients with severe COVID-19 symptoms. Again, no one's really answered or has chosen this answer either. And in this case, under the EUA, it's actually not authorized to give Paxlovid to these individuals who are hospitalized and who have severe COVID-19 symptoms. And then overwhelmingly, again, answer choice C was chosen, and that's correct. Our individuals who can receive Paxlovid must have mild or moderate COVID-19 symptoms. And when we talk about some of the literature and what rebound COVID-19 looks like after Paxlovid, I think you'll see a trend with the severity of those symptoms. And some of that might have to do with the severity of individuals' COVID who are eligible to receive Paxlovid. Answer choice D, patients exposed to COVID-19 as a preventative measure. In this case, this is not recommended underneath the authorization. So it's not authorized, again, for these individuals. And then finally, for patients taking necessary CYP3A drugs, we also have a contraindication for its use with those medications. So again, answer choice C, Paxlovid can be utilized in patients with mild to moderate COVID-19 symptoms. All right, we'll move on to our next knowledge check. I'm trying to write this as clear and legible as I can. I'm using a pen on the screen here, so we'll see if we can get this to look good. All right, next question is, what drugs do not need to be discontinued if starting a patient on Paxlovid? There's more than one answer choice in this case. Give you some time to think about it, and then we'll go through all of the different medications. Alrighty. I'm seeing some answer choices coming in. Most people are saying that there's two agents that we want to avoid, or that are okay to take with Paxlovid, and seems like lisinopril and losartan are the agents that most have identified. So excellent. Okay, well that is the correct answer. We'll go through some of the other agents and identify why they may or may not be okay to take with Paxlovid. So first off, phenytoin. We often think of this being a 2C9 inducer and a CYP3A inducer. And so being a substrate or an inducer for 3A, we're not going to want to use phenytoin. Lorazepam, we also have issues with this being a substrate for CYP3A as well. So we don't want to use that. Lisinopril, on the other hand, as most of you guys have noted, is actually excreted in the urine unchanged. So I'm just going to put a change symbol and put no change. So that is a correct answer. Next, we have amiodarone. I didn't see anyone select amiodarone as being appropriate to take with Paxlovid. That is because it is also a substrate for CYP3A. Obviously, seeing a strong trend here, and colchicine as well, not an answer choice that I saw many people select. So this is also a substrate for CYP3A. Lovastatin, another medication, we'll just put quotes this time. It is also another medication that is metabolized by CYP3A. Losartan, on the other hand, is not one of those medications. So C and G, like we mentioned, is correct. Both of these agents are appropriate to take with Paxlovid. Losartan, we have some glucuronidation and some hydroxylation as well. So we'll just abbreviate it like that. Fantastic. All right. So let's move on to our next segment. We'll learn a little bit more about rebound COVID-19 and some hypotheses for why this might occur. All right. So rebound COVID-19 after nirmatrelvir or ritonavir. COVID-19 rebound is characterized by a recurrence of symptoms or a new positive viral test after having tested negative for COVID-19 previously. And as you might expect, the symptoms that individuals present with are obviously very similar to those symptoms of COVID-19. Some of our hallmark symptoms like fever or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, and of course, loss of taste or smell. And then other symptoms like sore throat, congestion, runny nose, nausea, vomiting, diarrhea as well. So the symptoms that we expect with rebound COVID-19 are really the same that we would expect with COVID-19 itself. So in terms of hypotheses, in terms of why COVID-19 rebound is occurring in patients, several have been proposed, but at this time, there's not really a true known reason why we think this might happen. So some individuals think that there's just insufficient drug exposure, that not enough of the drug, too low of a drug concentration to stop all viral replication in these individuals. Others have proposed that the drug is metabolized more quickly in some individuals. So this could be a sort of a pharmacogenomic issue with CYP3A, perhaps, with maybe ultra rapid metabolizers or something along those lines. Others have proposed that the drug needs to be delivered over a longer treatment duration. When it was tested, we did test it under 5 days of treatment. And so that's one of the main reasons why individuals consider this to be a potential reason for for rebound COVID-19. Evidence also indicates that rebound COVID-19 may not be unique to Paxlovid alone. As we'll talk about shortly, we've seen this with molnupiravir as well, although perhaps not to the same degree that we've seen it with nirmatrelvir or ritonavir. Ultimately, more studies need to be conducted to really identify a strong rationale and reasoning as to why rebound COVID-19 occurs in patients. All right. So the CDC have the following recommendations. Now, these are from May of 2022, but those are still on their website as their recommendations. And so we wanted to present these as well. So they've said that people with COVID-19 rebound should follow CDC recommendations regarding isolation of infected patients, regardless of treatment with an antiviral agent or previous isolation after the initial infection. They also go on to indicate that people with recurrence of COVID-19 symptoms or a new positive viral test after having tested negative previously, that they should still restart isolation and isolate for at least 5 days. They can end their re-isolation period after 5 full days if fever has resolved for 24 hours and symptoms are seem to be improving in those individuals. These individuals should still wear a mask according to the CDC and back in May for a total of 10 days after rebound symptoms have started. Some people continue to test positive after day 10, but are considerably less likely to shed infectious virus. Cool. So final knowledge check before we jump back into evaluating the literature that's available. Rebound COVID-19 symptoms are significantly different from traditional COVID-19 symptoms. And unique CDC guidelines for isolation should be followed. Kind of a trick question, right? So yeah, the symptoms themselves are not significantly different than we see with COVID-19 itself. Excellent. In addition to this, there are some alternative agents that I think it's worthwhile to be aware of. Obviously, patients with COVID-19, there are two therapies that we typically discuss, Paxlovid and remdesivir being the two main preferred agents. But there's also recommendations when circumstances arise where these medications may not be preferred in certain patients. So in those cases, bebtelovimab and molnupiravir may be used to help treat patients with COVID-19. All right. So let's take a moment to look at some of the literature that's available. As you'll see in just a moment, most of the literature that's available is confined to cohort studies and some case series that have been made available. So we don't often see our large randomized controlled trials in these types of circumstances very frequently, especially when we're looking at potentially something that might potentially harm a patient. And you might see it in some of their secondary data sets in some of those randomized controlled trials, but most of what we have now is all available in some retrospective observational types of studies, which is kind of to be expected. So let's jump onto this next segment here, and I'll look at the chat and see what questions I have and try to answer those after this next segment.
For this continuing education program, we'll cover the available literature on rebound COVID-19 following nirmatrelvir ritonavir from recently published studies. These studies fall under two categories: retrospective cohort studies and case series. Two of the retrospective cohort studies were published in highly reputable journals: the Center for Disease Control and Prevention Morbidity and Mortality Weekly Report, or MMWR, and Clinical Infectious Diseases. Both journals are frequently cited by scholars in public health and infection, as well as immunity. The first study that we'll discuss was a retrospective cohort published in medRxiv in 2022. This study included 13,644 patient records from a nationwide United States database. The authors sought to examine the rate and relative risk of COVID-19 rebound in patients treated with nirmatrelvir and ritonavir or with molnupiravir, and compare the characteristics of patients who experienced COVID-19 rebound to those who did not. To be included in this study, patients needed to be at least 18 years old, have contracted COVID-19 between January 1st, 2022 and June 8th, 2022, and have been treated with nirmatrelvir and ritonavir or molnupiravir within 5 days of testing positive for COVID-19. Those who took nirmatrelvir, ritonavir, and molnupiravir were excluded from the study. To reduce the risk of biasing results, patients were matched based on several characteristics available in the database: age, sex, ethnicity, race, socioeconomic determinants of health, and pre-existing conditions such as type 2 diabetes mellitus. 3 types of COVID-19 rebound outcomes were evaluated: the rate of COVID-19 infection, COVID-19 related symptoms, and COVID-19 related hospitalization. Authors also compared the characteristics of patients with and without COVID-19 rebound. Hazard ratios and 95% confidence intervals of 7-day and 30-day risk for COVID-19 rebound between patients treated with nirmatrelvir and ritonavir and patients treated with molnupiravir were calculated before and after propensity score matching. There was no statistically significant difference between 7-day risk for COVID-19 infections between nirmatrelvir, ritonavir, and molnupiravir when accounting for COVID-19 infections with symptoms and hospitalization. Likewise, No differences in these variables were noted 30 days after receiving the study agent either. For both groups, the rate at which COVID-19 rebound infections occurred at 7 days was between 5 to 6%. And at 30 days, the rate was about 7 to 8% of patients receiving these agents. Hospitalizations occurred in about 1% of patients after taking the study drug. Although without a control group, it's difficult to ascertain the extent that these agents played in these rebound infections. Several characteristics were associated with rebound COVID-19 in patients taking nirmatrelvir and ritonavir: age, female sex, not having Hispanic ethnicity, and having COVID-19 vaccine documentation. Notably, having COVID-19 vaccine documentation was a characteristic also associated with COVID-19 in the molnupiravir group. Pre-existing conditions associated with rebound COVID-19 in the nirmatrelvir and ritonavir group were chronic lower respiratory disease, obesity, immune system disorders, organ transplant, and immunosuppression. The second study we'll discuss was published in Clinical Infectious Diseases in June 2022. This was a single-center, retrospective cohort study of patients who received nirmatrelvir, ritonavir at Mayo Clinic in Rochester, New York. This study included 483 patients. Patients were included if they had confirmed diagnosis of symptomatic SARS-CoV-2 infection prior to initiation of nirmatrelvir or ritonavir, improvement in most or all symptoms during therapy with nirmatrelvir or ritonavir, and absence of an alternate explanation for recurrent symptoms. Those who failed to complete the 5-day course of nirmatrelvir or ritonavir lacked significant improvement in symptoms or had persistent symptoms signifying long COVID were excluded from the study. Each patient was assigned a monoclonal antibody screening score and COVID antibody screening tool score
that categorize a person's risk for severe disease progression to facilitate appropriate allocation of nirmatrelvir ritonavir therapy. If eligible, patients were given oral nirmatrelvir ritonavir, intravenous remdesivir, or intravenous monoclonal antibodies. Records were reviewed to identify rebound COVID-19, defined as recurrence of COVID-19 symptoms following successful completion of 5 days of nirmatrelvir ritonavir therapy, and was assessed for up to 30 days after treatment. Within 30 days of administration of nirmatrelvir ritonavir, 2 or 0.4% of patients were admitted to the hospital. 2 were admitted to the ICU, and no deaths occurred. The incidence of rebound COVID-19 in this group of 483 patients was 4, or 0.8%. The average duration of symptoms was 9 days. The study suggests that general incidence of rebound COVID-19 following nirmatrelvir ritonavir is low. The third study we'll discuss was published in the Morbidity and Mortality Weekly Report, or MMWR, in June 2022. This study was also a retrospective chart review of patients who received nirmatrelvir ritonavir after a COVID-19 diagnosis. In total, 5,287 charts were reviewed. The objective of this study was to describe hospital admissions and emergency department encounters related to SARS-CoV-2 infections during the 5 to 15 days after pharmacy dispensation of a 5-day treatment course of nirmatrelvir ritonavir. Investigators collected EHR data of patients from Kaiser Permanente, Southern California, if the patient was treated with nirmatrelvir ritonavir during the time frame of December 31st, 2021 to May 26, 2022. All EHRs of patients who received nirmatrelvir ritonavir were flagged if hospitalization and/or emergency department encounters occurred 5 to 15 days after nirmatrelvir ritonavir treatment. A medical chart review was performed on each flagged EHR to confirm that the hospitalization or emergency department encounter was COVID-19 related,
either the primary reason for that encounter or if there was documentation of COVID-19 symptoms consistent with the latest Centers for Disease Control and Prevention definition. Patients were considered to have a confirmed COVID-19 related hospitalization or ED encounter if the EHRs indicated documentation of known symptoms consistent with COVID-19 illness. Patients were included in this study if they had documentation in their EHR that the pharmacy dispensed nirmatrelvir/ritonavir for the treatment of COVID-19. No exclusion criteria were provided. Of the 5,287 patients included in the study, 6 of these patients were inpatient hospitalizations and 39 were treated in the emergency department. The outcome of interest in this study was COVID-19 related hospitalization and emergency department encounters 5 to 15 days after nirmatrelvir/ritonavir was dispensed. The researchers identified 6 of the 5,284 patients who received nirmatrelvir/ritonavir were hospitalized during the 5 to 15 day period, and 39 emergency department encounters were noted in this population as well. 46.7% of patients who were hospitalized or had an emergency department encounter were over the age of 65, and 78% of patients had at least one underlying medical condition. Additionally, while patients who were unvaccinated or vaccinated with only one dose of the vaccine made up 9.7% of the patient population, these individuals made up 17.8% of the patients who were hospitalized or who had emergency department encounters. 50% of hospitalized patients had a positive COVID-19 test result, but only 25% of patients reported to the emergency department had a positive test result. 2 deaths did occur in the hospitalization group, while no deaths occurred in the emergency department encounter group. Ultimately, these 3 studies provide some insight into the degree to which rebound COVID-19 may occur in patients who took nirmatrelvir/ritonavir for COVID-19 infection, as well as some potential risk factors for developing rebound COVID-19 and the severity of illness associated with rebound COVID-19. The authors of the first study conclude that rebound COVID-19 is not unique to patients taking nirmatrelvir/ritonavir, and that those taking molnupiravir also experience this rebound event. The rates of COVID-19 rebound increase with time after treatments. And studies are also necessary to determine the mechanisms underlying COVID-19 rebound and to test dosing and duration regimens that might prevent such rebounds in vulnerable patient populations. With that being said, it's important to note that this specific study was a retrospective observational study, and therefore no causal inferences can be drawn in regard to factors that may be linked to rebound COVID-19 after nirmatrelvir/ritonavir treatment. Additionally, there are inherent limitations and unmeasured confounders that could skew results from studies that are based, like this one is, solely on patient electronic health records. In our second study, we got further insight into the severity of rebound COVID-19 infections. Authors concluded that rebound after nirmatrelvir/ritonavir treatment is uncommon in their population of high-risk but mostly non-immunocompromised patients. Among the patients who developed rebound symptoms after nirmatrelvir/ritonavir treatment, the clinical presentation was mild and did not require COVID-19 direct therapies. In their cohort, the outcomes of patients with rebound phenomenon were very good overall. As the study authors noted, this is a study that is not broadly applicable, as the patient populations that were included typically had high vaccination rates, and those with immunocompromising conditions were generally underrepresented. Thus, the rebound incidence could vary in a broader population, with high-risk patients. Takeaways from our third study were that less than 1% of patients treated with nirmatrelvir/ritonavir were identified with COVID-19 related hospitalizations or emergency department encounters 5 to 15 days after treatment was dispensed. When administered as an early stage treatment, nirmatrelvir/ritonavir might prevent COVID-19 related hospitalizations among patients with mild to moderate COVID-19 cases who are at risk for progression to severe disease. Additional research is warranted to provide further understanding of the apparent association between nirmatrelvir-ritonavir and reduced risk for severe COVID-19 illness, including studies with control groups and more precise indicators of COVID-19 illness severity. Finally, let's look into the available case series that discuss rebound COVID-19 to learn more about patient experiences with COVID-19 after nirmatrelvir-ritonavir. The first case series describes two patient experiences. The first patient was an 87-year-old male who had been vaccinated against COVID-19, was diagnosed with COVID-19 at his nursing home with symptomatic shortness of breath, cough, fatigue, and myalgia. He received nirmatrelvir-ritonavir 300 mg, 100 mg, twice daily on day 0 of his COVID diagnosis for 5 days. His symptoms improved after the completion of his treatment. However, on day 11 of his diagnosis, he experienced worsening shortness of breath and was sent to the emergency room. Upon admission, his vitals and physical examination were within normal limits. Significant labs were his white blood cell count of 18.52, lymphocyte count of 0.74, thrombocytes of 434, D-dimer of 560, serum creatinine of 0.8, C-reactive protein of 102.8, lactic acid of 1.2, and procalcitonin of 0.09. Nasal SARS-CoV-2 PCR test came back positive with negative blood cultures. A CT scan showed acute bilateral pulmonary infiltrates in his lower lobes. During his hospitalization, he received treatment for his symptoms, and by day 19 of his COVID diagnosis, he was discharged to subacute rehabilitation. The second patient in this series was a 72-year-old female who received 2 doses of COVID-19 vaccines and was diagnosed with COVID-19 14 months after her second vaccination. She presented with symptomatic shortness of breath, cough, and fatigue, and received nirmatrelvir-ritonavir 300 mg, 100 mg twice daily for 5 days on day 0 of her diagnosis. While her symptoms initially improved during the treatment, she started to experience worsening shortness of breath and fatigue and developed pleuritic chest pain and palpitations. On day 14 of her COVID-19 diagnosis, she had episodes of hypoxia at home with oxygen saturations down to 80%. Laboratory results showed a white blood cell count of 21.92 with an absolute lymphocyte count of 1.32, C-reactive protein level of 18.4, procalcitonin level of 0.08, and on day 17, she was sent to the emergency department with an elevated D-dimer of 1,750. A CT scan showed diffuse patchy opacities. Her respiratory viral panel came back negative, but a SARS-CoV-2 PCR test was positive. Her symptoms did improve with symptomatic and supportive care during hospitalization, and she was discharged home on day 20 of COVID-19 diagnosis. In our second published case series, several data points were made available in a short letter to the editor about 3 patients who experienced rebound COVID-19 after nirmatrelvir-ritonavir therapy. Patient ages were 55, 44, and 59 years. Nirmatrelvir-ritonavir was started on days 2, 4, and on day 2 in these patients, but duration of therapy differed amongst the 3 patients. Each patient also had at least one comorbidity. None of these patients, however, were admitted to the hospital, and symptoms began to improve during treatment with nirmatrelvir-ritonavir. Each of these 3 patients experienced rebound COVID-19. Patient 1 experienced this on day 8, patient 2 experienced this on day 14, and patient 3 experienced rebound COVID-19 after nirmatrelvir-ritonavir on day 19. General takeaways from these cases are that authors also noted that patients with this COVID-19 rebound had mild symptoms during this rebound phase and required no further antiviral treatment. although our 87-year-old nursing home patient did require an emergency department visit. Experiences from these 5 patients also suggest that rebound COVID-19 more commonly occurs 7 days after receiving nirmatrelvir-ritonavir therapy. All in all, both the Centers for Disease Control and Prevention and the United States Food and Drug Administration issued an update in May of 2022 regarding the development of COVID-19 symptoms again after completing treatment with nirmatrelvir-ritonavir. Now, the mechanism of this rebound phenomenon still remains unclear, and the 7-day risk for COVID-19 rebound infection has been found to be as high as 4.5% after treatment with nirmatrelvir and ritonavir. However, other researchers have observed rebound incidences of less than 1%. Although the data that we have at this point is limited to observational retrospective studies, it appears that symptoms from COVID-19 rebound are generally mild in most patients, though these data also suggest that patients with underlying medical conditions may be more likely to experience rebound COVID-19 following treatment with nirmatrelvir-ritonavir therapy.
All right, folks. That's the end of our CE today. I hope that the audio issues got fixed for most of you. Sounds like connection kind of got better and things improved a little bit on our end. I think the big takeaways, like I mentioned in the videos, were, this is a product Paxlovid is a product that is approved for individuals with mild to moderate COVID. And I think it's important to note that the symptoms that they presented with rebound COVID were also considered to be mild as well at the end. Well, they had mild to moderate COVID beforehand, so I would expect, be a little bit surprised if their rebound symptoms were much different. Someone did mention that, even without regard to Paxlovid, we're seeing patients that come into our hospitals with COVID-19, have some pretty severe symptoms, seem to be improving, go home, right? And then we have some of those rebound symptoms that come again and certainly could get worse. And certainly some individuals, especially early on, were noted to have passed away in those instances. And so, yeah, we certainly see that. This seems to be a little bit different than that in terms of some of the retrospective studies. Again, like we've mentioned, not the best study design per se, but that's what we have to kind of go on and base the data on so far. But it sounds like that may be a little bit different. Another person had mentioned, why not give Paxlovid for 10 days? And I'm not familiar with the data around the use of Paxlovid after 5 days. I think that's what the EUA authorizes it for. So I'm not certain about the data after that. Let's see. Another person mentioned that they had seen some great success with molnupiravir, and that's fantastic to hear. It's like another person said, like, I haven't seen any data after 10 days, and that's fantastic. I'm on that same track as well, it sounds like. Another person asked whether or not these studies break down which vaccines patient received. I have not seen necessarily a breakdown in terms of which vaccine they received and whether or not when they did have COVID, they were more likely to have a rebound. I have not seen any data on that. But that is an interesting thought or question to kind of see how some of these vaccines are helping us out. All right, any further questions?